You're tuned in to the deep dive, and today, well, we're tackling a topic that really hits close to home for many of us animal lovers: oral melanocytic tumors in our dogs and cats.
That's right. We've been digging through the expert knowledge specifically from oral melanocytic tumors in animals to bring you the essentials.
Exactly. We want to give you a clear picture of this type of cancer affecting our companions.
And our mission today is really just that, to understand these tumors. What makes this so important and maybe a bit surprising for you is that these are actually the most common malignant cancerous mouth tumor in dogs.
Wow, the most common?
Yes, and the third most common in cats. So it's a pretty significant issue, and being informed is, well, it's vital.
Okay, definitely important then. So let's get right to it. What exactly are these oral melanocytic tumors we're discussing?
So basically, these tumors start in melanocytes. Those are the cells that make pigment.
Okay, the color cells.
Exactly. And they develop right there in the mouth, the gums, the palate, which is the roof of the mouth, even the tongue. But here's the really crucial part. They are most often malignant.
Malignant. Yeah, that's the word everyone dreads. What does that mean in this situation for our pets?
Right. Well, malignancy here means a couple of things. First, they tend to be locally invasive.
Meaning they spread into nearby tissue?
Precisely. They grow outwards into the tissues right around them. And second, and this is especially concerning in dogs, they have a really high rate of metastasis.
Spreading further away.
Yes, we're talking over 75% of canine cases. It's like the cancer cells travel. They can go to the lymph nodes, the lungs, sometimes other areas too.
That's a tough reality. And it's not just the soft parts of the mouth, is it? Can it affect bone?
Correct. When they're malignant, these tumors can absolutely invade the underlying bone. So you're looking at impact on the mouth itself, plus those common places cancer spreads.
And do we know why this happens? Like the genetics behind it?
That's still a bit of a mystery, actually. Researchers are definitely working on understanding the specific genetic triggers, but right now it's largely unknown.
Got it. So who is most at risk then? Are certain animals more likely to get these?
Yes, definitely. While both dogs and cats can get them, they are much, much more common in dogs.
Okay, dogs more than cats. Any specific breeds?
There are certain dog breeds seem to pop up more often. Think Cocker Spaniels, miniature poodles, retriever breeds.
Like labs and goldens.
Exactly. And interestingly, Chow Chows seem to have a higher risk specifically for tumors on the tongue.
That is interesting. What about cats? You said it's less common, but are there any cat breeds we should know about?
You know, the information we have doesn't really point to specific cat breeds being more prone. We do see it in cats, just not nearly as often.
And age plays a role too, I assume.
It does. For dogs, the average age when diagnosed is around 11 years old. But there's a pretty wide range, say 5 up to 18 years.
Wow, 5 is quite young.
It can happen. For cats, the average age is a bit older, around 12, and the range seems a bit tighter, maybe 11 to 15 years old.
And what about males versus females? Any difference there?
There might be, in dogs at least. Some studies suggest male dogs could have a slightly higher predisposition.
But not in cats.
Not that that's been reported, no.
Okay. So we know who might be more likely to get it. What are the signs? What should owners like you be looking for at home? What are those early warnings?
Right, the things that should make you think, something's not quite right here. Definitely watch for excessive drooling or really bad breath halitosis that just doesn't go away.
Okay.
Also, difficulty swallowing. Maybe your pet seems hesitant to eat or drops food. Any kind of bloody discharge from the mouth is a big one. And unexplained weight loss.
Those all sound like pretty clear red flags. Now, what might a vet see during an exam that would make them suspicious?
Well, the most obvious thing is finding a mass, a growth, in the mouth. But here's something really important for you to know. Up to a third of these tumors can be poorly pigmented, or even have no pigment at all. They might just look pink or flesh-colored.
Oh, wow. So not always the dark black lump you might expect with melanoma.
Exactly. Don't dismiss a growth just because it isn't dark. The mass itself often feels kind of crumbly. Friable is the term, and might bleed easily if touched.
Okay, friable. Got it.
Other signs could be loose teeth near the mass, maybe some swelling, or even a change in the shape of the face. Sometimes, if the tumor is high up at the jaw, it can cause the eye to bulge a bit. That's called exophthalmos.
Right.
And the vet will definitely feel the lymph nodes under the jaw and in the neck area, checking if they're enlarged. And, of course, signs of pain when examining the mouth.
That non-pigmented point is really crucial. So Color isn't everything. Once a vet finds something suspicious, how do they figure out exactly what it is? What's the diagnostic process?
Okay, so the first thing is to consider other possibilities. What else could this be? We call those differential diagnoses. It could be another type of oral tumor, maybe a non-cancerous gum growth called an epulis, or even just overgrown gum tissue, gingival hyperplasia, or maybe an infection at the root of a tooth.
So, ruling things out, do standard blood tests help much here?
Typically, no. Routine blood work, urine tests, they usually come back normal in animals with these tumors. So we need more specific tests.
Okay, more specific. Is that where things like immunohistochemical markers come into play? Sounds complex.
It sounds technical, but think of them like special tags we can use in the lab on the tumor cells.
Tags.
Yeah, they stick to specific proteins found in certain cell types. This is super helpful, especially with those non-pigmented melanotic tumors, because it helps us confirm if it's actually melanoma when the pigment isn't there to give us a clue under the microscope.
Oh, okay. So they help identify it.
Exactly. There's several markers we look for, things like Vimentin S100, NSE, HMB45, and one called melan A. Melan A is very specific to melanocytes, but it's not always present, so often a panel of these markers gives the best picture.
Like piecing together clues. What about imaging? X-rays, CT scans. How do they fit in?
Imaging is critical for seeing how far the tumor goes. Good quality skull or dental X-rays can show if the tumor is damaging the bone. We look for what's called osteolytic changes, basically bone being eaten away.
Right.
But for much better detail, especially in the upper jaw, or for planning treatment like surgery or radiation, we often turn to advanced imaging like CT or sometimes MRI.
Gives us a clearer view.
A much clearer view. And importantly, we need to check for spread, for metastasis. So chest X-rays or a chest CT are standard to look for spread to the lungs.
And maybe the belly, too.
Occasionally, yes. An abdominal ultrasound can be done for complete staging, just to check organs in the belly, though distant spread there is less common initially compared to the lungs.
Okay. But to be absolutely sure what it is, you need a piece of the tumor itself, right? A biopsy.
Absolutely. The definitive diagnosis comes from histopathology, looking at a tissue sample under the microscope. It's really important to get a good-sized, deep biopsy sample taken directly from the mass inside the mouth.
Not through the skin.
Preferably not, if surgery is planned, as it can complicate things. And besides the tumor biopsy, we strongly recommend sampling the nearby lymph nodes, the mandibular and retropharyngeal ones.
Even if they don't feel swollen.
Yes, even if they feel normal. Cancer cells can be hiding there. We usually do that with a fine needle aspiration, sucking out some cells to look at. That's cytology.
Got it. Biopsy the tumor, sample the nodes. So we know how it's diagnosed. What does the tumor actually look like? Grossly, I mean, when the vet sees it.
Yeah, grossly, they often look ulcerated, like an open sore and friable, remember? Crumbly and prone to bleeding. The color is really variable. It can be amelanotic, so pinkish.
Right, the non-pigmented ones.
Or it can range from dark brown to gray or even black. Size varies a lot too, and they often look like they're growing into the surrounding tissue, invasive.
And under the microscope, cytology first, maybe from that needle aspirate.
With cytology, if it's pigmented, you might see these characteristic brown, sort of rod-like granules of melanin inside the cell. Right. But again, you won't see those in the melanotic types. In the lymph node samples, you might see immune cells called melanophages that have actually eaten some melanin pigment. And in the malignant tumors, the cancer cells themselves usually look pretty abnormal, what we call atypia.
Okay, and then the full biopsy, the histopathology, gives even more detail.
Exactly. Histopathology shows the architecture. The cells can have various shapes. The amount of pigment is variable. The key features that tell us it's malignant are things like a high mitotic index.
Meaning cells dividing rapidly.
Yes, lots of cell division. Also, the cell's nuclei and other internal structures look abnormal, pleomorphic. And we look carefully for signs of invasion into adjacent tissues.
And this is where those markers are helpful again for the tricky ones.
Absolutely. For the melanotic ones, immunohistochemistry can be essential for confirmation. A good pathology report will tell us about that mitotic index, the degree of atypia, invasion, and crucially, if surgery was done, whether the surgical margins, the edges of the removed tissue are clean.
Margins are key for surgery.
Very key. And sometimes proliferation markers can give us extra clues about how aggressively the tumor might behave.
This is a lot to process. Okay, let's shift to the big question. How do we treat these?
Right, treatment. Often this requires inpatient care, especially for the aggressive surgeries sometimes needed. And something absolutely mandatory is multimodal analgesia.
Meaning multiple types of pain control.
Yes, managing pain effectively before, during, and long after any procedure is crucial. Post-surgery, activity restriction is important for healing.
Let things mend.
Exactly. And usually a soft food diet is recommended for a while, avoiding hard toys or chews until the mouth is healed up.
And talking to the owner, client education must be huge here. What do you need them to understand?
Oh, absolutely critical. We need to explain the whole staging process, understanding how far the cancer has spread. We need to emphasize that early, aggressive surgical removal usually offers the best chance.
Get it out early.
Yes, but owners also need to understand the reality, especially with malignant melanoma in dogs. The high likelihood of early spread, which means the prognosis can be guarded, even with treatment.
Managing expectations.
Right, and explaining why adjuvant therapy, additional treatment after surgery, is often recommended to try and combat that spread. And that follow-up, repeat staging, is necessary.
Okay, let's talk surgery more specifically. What's the goal? What procedures are common?
The goal is complete removal with clean margins, getting all the cancer cells out with a border of healthy tissue around them.
How much of a border?
Ideally at least 2 centimeters. Studies show that achieving wide, clean margins like that improves survival. Because these tumors are invasive, this often means quite radical surgery.
Like removing part of the jaw.
Yes, a mandibulectomy, removing part of the lower jaw, or a maxillectomy, part of the upper jaw. These are called en bloc excisions, removing the tumor in one whole piece with surrounding structures.
That sounds major.
It is major surgery, but honestly, dogs and even cats tend to tolerate these procedures remarkably well afterwards. They adapt surprisingly quickly.
Good to know. And what about the lymph nodes?
If those pre-treatment aspirates confirmed metastasis to the regional lymph nodes, or if they look highly suspicious and there's no sign of spread elsewhere, then yes, surgically removing those draining lymph nodes is recommended too.
Okay. What if surgery isn't possible or can't get it all? Is radiation an option?
Yes, radiation therapy can be a very good option, particularly for tumors that are inoperable or where surgery couldn't achieve clean margins.
How does it work here?
Melanomas often respond well to protocols using fewer, larger doses, higher fractions of radiation. We often use megavoltage radiation, maybe 3 to 6 treatments given weekly or sometimes twice weekly. It can provide good local control.
Shrink the tumor, control it locally. Got it. What about medications? Chemotherapy? Other drugs?
Well, for dogs, a chemotherapy drug called carboplatin has shown some response, maybe shrinking the tumor in about 30% of cases.
Yep.
It hasn't clearly shown a survival advantage when used as an adjuvant therapy after surgery. For cats, unfortunately, there's really a lack of effective chemotherapy described for oral melanoma.
That's tough for cats.
It is. Pain management, as we said, remains vital. Now, immunotherapy is an area with ongoing research.
Like boosting the body's own defenses.
Exactly. There have been varied results with different approaches, but there is a therapeutic vaccine available for dogs.
A vaccine to treat cancer?
Yes, specifically for dogs with stage 2 or through oral malignant melanoma used after surgery. It uses human DNA coding for an enzyme called tyrosinase, which is involved in melanin production. The idea is to stimulate the dog's immune system to target melanoma cells.
And does it work?
Studies have shown it can significantly improve survival times for dogs in those stages, compared to surgery alone. It's become a really important part of treatment for many dogs.
That's hopeful. Are there any treatments that should definitely be avoided?
Yes. A chemotherapy drug called cisplatin, it's very toxic to cats, causes severe lung problems, so it's contraindicated. Big no-no in cats.
Okay, no cisplatin for cats.
And generally, if a vet isn't familiar with handling these potent cytotoxic drugs, consulting with or referring to a veterinary oncologist is always the safest bet. You need to know the risks and how to manage side effects.
Good advice. Any other drug considerations?
Just being mindful of overlapping toxicities if multiple drugs are used. Oh, and sometimes a nonsteroidal anti-inflammatory drug or NSAID like piroxicam might be used. It helps with pain and inflammation, and there's some limited evidence it might have some anti-tumor effect itself, possibly slowing progression in some cases.
Interesting. Okay, so the pet has had treatment surgery, maybe radiation, maybe the vaccine. What happens next? What's the follow-up?
Patient monitoring is key. Regular checkups are essential. We're talking maybe every 2 to 3 months initially, or sooner if the owner sees any changes.
What are you looking for?
We're checking for local recurrence, the tumor coming back in the same spot, and for spread to the regional lymph nodes. Palpating those nodes, carefully examining the mouth. We also recommend periodic chest x-rays, maybe every 3 to 6 months, to monitor for lung metastasis.
And prevention. Is there anything you can do to stop these from forming?
Unfortunately, no. There's no known way to prevent oral melanocytic tumors.
Right. What about complications from the treatments themselves?
There can be. After those big surgeries, poor wound healing, the wound coming open, dehiscence or infection are possibilities.
Mm-hmm.
With radiation, early side effects can include mucositis, which is inflammation inside the mouth, or dermatitis, skin inflammation in the treatment area, depending on the protocol used.
Okay. And the big picture, the expected course, the prognosis. What can owners realistically expect?
This is the tough part. If left untreated, the prognosis is very poor. Median survival is often only around 2 months.
Wow, that quick.
Yes. With treatment, the outlook really hinges on the stage of the disease at diagnosis. Stage I, small tumor, no spread, has the best prognosis.
Makes sense.
Complete surgical excision, getting those clean margins we talked about, including involved lymph nodes, is critical. For dogs with stage I treated with surgery alone, median survival can be over 18 months, which is pretty good.
And the later stages?
For stage 2 and 3, surgery alone usually yields survival times more in the range of 5 to 12 months. But this is where the tyrosinase vaccine can make a real difference in dogs, potentially pushing that survival beyond 18 months for some.
Okay, so the vaccine adds significant time for those stages.
It seems to, yes.
Sure.
Stage 4, unfortunately, where it's already spread distantly, like to the lungs, the prognosis is grim. Less than 3 months, typically.
And radiation alone, if surgery isn't done.
For dogs treated with just radiation, survival times are often reported in the 6 to 10 month range.
What ultimately causes death in most cases?
In dogs, it's usually either metastatic disease, the spread, or local recurrence that becomes unmanageable.
And what about cats? You mentioned it's tougher for them.
Yes. Overall prognosis in cats is generally poor. The tumors tend to be very locally aggressive, and they're often diagnosed late. Death is frequently due to the tumor just progressing locally, becoming too large or invasive in the mouth. Even with treatment like radiation, median survival times reported in small studies are often under 6 months, maybe around 146 days in one study of 5 cats.
So it's a much tougher fight in cats.
It generally seems to be, yes.
Okay. So pulling this all together for everyone listening, we've learned that these oral melanocytic tumors are, well, a really serious concern, particularly in dogs, because they're so often malignant and spread early.
That's a key takeaway.
And it's so important for you, the owner, to remember they aren't always dark. That pink or flesh-colored lump needs checking, too.
Absolutely. Don't rely on color alone.
Early detection, getting it checked by a vet quickly, and then aggressive treatment, often surgery, maybe combined with radiation, or that vaccine for dogs that seems to be crucial for giving our pets the best possible chance.
You've summed it up well. And this deep dive really should leave you, the listener, thinking about, well, how often do you really look inside your pet's mouth?
Good question.
Given how aggressive these can be, and how subtle the early signs might seem, just being proactive, knowing what's normal in there for your pet, and noticing changes early, that can make such a difference. Are you comfortable doing that?
It's a great point. Vigilant observation at home plus prompt vet checks are really our best tools against this.
Couldn't agree more.
Absolutely. So if anything we've discussed today has sparked a concern about your own pet, please don't wait. Reach out to your veterinarian. They're your partner in keeping your furry family healthy. Thanks for joining us for this important deep dive.
Thanks for listening.
We'll catch you next time.